Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be starting a series of lecture videos, and given that it is Cardiology Week, please do not forget to subscribe to the channel. Hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. So today we're going to be looking at pretty much valvular pathologies, and we shall be focusing on mitral stenosis in this review lecture video. Now remember that you have valves in between the heart. So let me just go to a black screen so that I can explain all these things, so that by the time we come to the PowerPoint, then it makes a lot more sense. So I shall draw what my lecturer never used to like us drawing, is representing the heart as a square. So I shall represent the heart as a square, sorry to my lecturer. So let's say this is the heart, right? The heart has 4 chambers. Okay, the upper chambers are known as inflow chambers. They are referred to as atria. So you have this as your right side, you have this as your left side. So here you have your right atrium over there. Here you have your left atrium. In between the two atria, you have what is known as the interatrial septum, which is this is the interatrial septum. Then here you have your right ventricle. Here you have your left ventricle. Remember that your left ventricle has a much thicker muscle mass than the right ventricle, because the left ventricle has to pump blood to the head and the rest of the body. Then there are valves that are going to be existing between the atria and between the ventricles. You refer to these as atrioventricular valves. So the valves that are going to be present on the right side, you're going to have a valve that has 3 leaflets, okay? 3 cusps. So it's referred to as a tricuspid valve. So this is the valve that's present on the right side, between the right atrium and the right ventricle. The valve that is present on the left side is known as the bicuspid valve, because it has 2 leaflets, an anterior and a posterior. So this bicuspid valve is also referred to as the mitral valve, which is what we're going to be focusing on, the mitral valve. Then recall that blood that's coming out from the left ventricle is going to be pumped out to the aorta. And of course, this is going towards the head and the body. So this is going to be pumped out through the aorta, and then eventually this is supposed to go and supply the head and body. So I shall say H and B. Okay, so the head and the body. So remember that this is the aorta right here, and there is a valve that is present now between the left ventricle and the aorta. It's referred to as a semilunar valve, specifically the aortic valve. So this is the aortic valve over here. Then recall that all the blood that is draining from this head and the body is going to be draining via the inferior and the superior vena cava into the right atrium, and this blood is supposed to be pumped to the right ventricle. In essence, the right ventricle is supposed to be pumping blood to go towards the lungs for the purpose of oxygenation. So the blood is going to be pumped out through this pulmonary trunk. And recall that the pulmonary trunk, there is a blood vessel, but the pulmonary trunk is a blood vessel that's going to be carrying deoxygenated blood, even though it's an artery. So there is a valve here, which is also a semilunar valve, that is referred to as your pulmonic valve or your pulmonary valve. Okay, so this is your pulmonary valve. Then of course this is going towards the lungs right there, and then this is for the purpose of oxygenation. And then from the lungs, this blood is going to be returning via the pulmonary veins into the left atrium and then to complete the cycle. So the cycle that is drawn in green here is known as the systemic circulation, SC. The cycle that is drawn in this blue color, this is known as the pulmonary circuit, so PC. Okay, so you have the systemic circuit and you have the pulmonary circuit, and you predominantly have 4 different types of valves in the heart. You have the ones that are on the right, you refer to these as the atrioventricular valves, which are between the atria and the ventricles. The one that's on the right is known as the tricuspid valve. The one that's on the left is known as the mitral valve or the bicuspid valve. Then you also have semilunar valves, which are between the ventricles and the large vessels. So between the left ventricle and the aorta, you have your aortic valve. Between the right ventricle and the pulmonary trunk, you have the pulmonic valve. So these valves are meant to prevent blood from backflowing whenever the heart is contracting. For example, when the left ventricle contracts in the phase of systole, the pressure inside the left ventricle is going to increase. So this will force the leaflets of the bicuspid valve to swing and shut close. So once they swing and shut close, it sends vibrations into the tissues, and that's what creates the first heart sound. So that's what prevents also blood from backflowing into the left atrium. Now, if the valve has some problem of some sort, maybe it has been damaged due to certain infections or certain congenital anomalies or other conditions that may be present in this individual, it may not be able to shut properly, and this blood may sometimes go back into the left atrium. So once it goes back into the left atrium, you refer to this as regurgitation. So that's one of the valvular pathologies. You could have regurgitation of the valve. So it could affect the mitral valve, it could affect the tricuspid valve, it could affect the pulmonary valve, it could affect the aortic valve. So if it's affecting the mitral valve, you refer to that as mitral regurgitation. If it's affecting the tricuspid valve, tricuspid regurgitation. If it's affecting the aortic valve, aortic regurgitation. If it's affecting the pulmonary valve, pulmonary regurgitation. Then in addition to this, you may sometimes have a valve, the opening of the valve becoming narrow. For example, if we are using the mitral valve as an example, the mitral valve has a surface area of about 4 to 6 centimeters squared. So if this surface area actually reduces, it means that now the space for the blood to move from the left atrium to the left ventricle has reduced. Okay, so the reduction in this space or the surface area of the valve across the valve is referred to as a stenosis. So it becomes narrowed. So it means that whenever blood is now moving across these valves pathologically, or there is a pathology affecting the valve, it will create a certain sound. It will create a specific heart sound, which is referred to as a murmur. We covered murmurs in our last video. I will leave a card at the end of this lecture to take you back to that, so that you can revise murmurs and actually have a good understanding of what they actually sound like. So if the mitral valve is narrowed, you refer to that as mitral stenosis. If the tricuspid valve is narrowed, you refer to that as tricuspid stenosis. If the aortic valve is narrowed, you refer to that as aortic stenosis. If the pulmonary valve is narrowed, you refer to that as pulmonic stenosis or pulmonary stenosis. Predominantly, there are some valvular pathologies of clinical significance that we will focus on. Then the ones that are not so clinically significant, we will cover them in one lecture. But the clinically significant valvular pathologies, we will cover them separately in their own individual lectures. Mitral regurgitation, mitral stenosis, aortic regurgitation, and aortic stenosis. With the tricuspid and the pulmonic valve pathologies, we will cover them in individual lectures. I hope that makes sense as a background or basis to this lecture. So let's now get back to the PowerPoint and see this. Recall that a valvular heart disease is going to be involving either an obstruction, an outflow obstruction, or narrowing, which we refer to as stenosis, or incompetence, which is referred to as regurgitation of one of the 4 valves of the heart. So recall that there are 4 valves, 4 heart valves: the atrioventricular valves, which are pretty much the mitral or bicuspid valve, which is found on the left side, the tricuspid valve, which is found on the right side, and the semilunar valves. Of course, you have the aortic and the pulmonary. Then the valvular heart diseases of clinical significance, like I already said, mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitations. Often you will be tested on these valvular pathologies on your exam. So recall that the distribution of these valvular diseases actually varies greatly across many populations, and it has many risk factors. But what we have noted is that the most common cause of valvular disease is either rheumatic heart disease in the background of rheumatic fever. Then you also have congenital anomalies, and it may also be due to some degenerative processes. But the commonest cause is obviously going to be rheumatic heart disease. And what you really need to note is that the definitive management of these valvular pathologies is going to be involving some surgical interventions, either opening up the valve in a way, or reconstructing the valve, or actually even replacing the valve. But because we are living in a third world country and we do not have such facilities to enable us to do this, most of the management that we're going to be carrying out in our setting is pretty much going to be managing the symptoms. So you want to treat the congestive heart failure state that is going to be created by these diseases. Then let's talk a little bit about mitral stenosis, since I've given you a background of valvular pathologies, as we will be covering these in Cardiac Week. Then recall that the mitral valve has two leaflets, an anterior leaflet and a posterior leaflet. It also has a fibrous annulus, chordae tendineae, and papillary muscles, which are reinforcing the valve itself. And it has a normal surface area of 4 to 6 centimeters squared. And mitral stenosis is just simply a valvulopathy or a valvular disease that's going to be characterized by narrowing of the opening of the mitral valve. And recall that the mitral valve is going to be between the left ventricle and the left atrium. So the mitral valve is what's going to be opening when blood is supposed to be moving from the from the left atrium to the left ventricle. So during that phase of diastole, during filling, the left atrium is supposed to contract and force open the atrioventricular valve. And once this opens, then the blood is going to fill into the left ventricle. Now, remember that opening of the valves that are normal should be without any sound. There shouldn't be any sound that is associated with opening of a normal valve. But because this valve is stenosed, it's narrowed. When blood is now rushing in from the atrium, the left atrium to the left ventricle, it's going to create a specific sound, which is known as a diastolic murmur. So mitral stenosis is going to be giving you a diastolic murmur because it's usually affecting the heart when it is filling. Again, I explained these murmurs very well in the previous video, so please head over there after you watch this video and it will make so much sense. Then, because now this blood is not going to be filling in the left ventricle, the left ventricle may actually become smaller than it normally will be because there will be some impaired filling. And the left atrium now, the pressures in the left atrium are going to increase. So it means that there's going to be a backflow of blood in the left atrium. And remember, where is all this blood coming from? It's pretty much coming from the lungs. So this blood is going to backflow in the lungs. There are going to be certain changes that may happen in the lungs. There may be increase in the thickness of the walls of the blood vessels in the lungs. There may be some vasoconstriction that may happen in the lungs. There may be an increase in the capillary pulmonary wedge pressures in the lungs. And to some extent, even the hydrostatic pressure increases. So it means there will be escape of fluid in the vessels in the lungs that may lead to pulmonary edema. There may be features of pulmonary hypertension. So this person may actually come in with features of respiratory distress because it's understandable there is some pulmonary edema. And in addition to this, what else is going to happen? There is pulmonary hypertension that's going to be there. So it means that even now the right side of the heart will find it much harder to pump and push blood to the lungs. So it means that it may predispose to right ventricular heart failure. And in addition to this, because of the backflow of this fluid from the left side of the heart to the pulmonary vasculature, there's going to be increase in hydrostatic pressure. And this increase in hydrostatic pressure can sometimes cause engorgement of the blood vessels, and they can actually rupture. So mitral stenosis is actually one of the causes of hemoptysis, which is pretty much coughing out blood. And recall that Mitral stenosis can actually coexist with mitral regurgitation, so you refer to that as a mixed valve disease. I will talk about what I've just explained in the pathophysiology, so if you do not understand it at how I explained it, just hold on a few slides down the line, you will understand it. So what are some of the causes? Again, sorry for the bulky slide here. So remember that the most common cause is rheumatic heart disease, and this is going to be in a background of rheumatic fever that's often due to an infection with group A beta hemolytic streptococci. And remember that this was a very huge problem, especially before the advent of antibiotics. The antibiotics coming into the scene have reduced the incidence of rheumatic fever. They have reduced the complication of rheumatic heart disease. So recall that this is a condition that's going to be affecting more women than it is affecting men. And it is very common in developing countries for obvious reasons, because rates of infections are very high. The usage of antibiotics is much less as compared to the first world countries. And of course, the age is going to be below 20 years. And generally, there is a latent period of about 20 to 40 years between the occurrence of rheumatic fever and mitral valve stenosis in developed countries. And of course, there's going to be some inflammation that's going to be affecting the heart valve. Now, this inflammation leads to fusion of the commissures of the valve, and therefore this is going to be reducing the surface area of the opening of the valve, and it actually gives it a characteristic appearance, and it starts to look like a fish's mouth. I don't know how I didn't include a picture for this, but it kind of looks like a fish mouth. Something like this. Okay, so it gets reduced. I don't know if you can see what's on my screen here. So it gets reduced like that, okay, to appear like as if it's a fish's mouth. Okay, I don't know if that looks like a fish mouth, but you can Google what a fish mouth looks like if you have no idea what a fish mouth looks like. So it gives you a fish mouth appearance of the valve. And then of course, with years and years of progression, the valve may begin to thicken, the cusps may actually fuse, there may be some calcium deposits, and it may sometimes be even severely narrowed. And of course, this is going to progress to immobility of the cusps of the valve. Then remember that rheumatic heart disease is not the only thing that can cause mitral stenosis. You have other causes such as congenital mitral stenosis, infective endocarditis, senile calcification, which is associated with increase in age. You also have fibrosis of the valve ring, and the subvalvular apparatus, pretty much the chordae tendineae. You also have some autoimmune diseases such as rheumatoid arthritis, systemic lupus erythematosus, and then you have Luton-Bashir syndrome. This is just simply a syndrome where you have pretty much an acquired mitral stenosis and an atrial septal defect. You may also have some mucopolysaccharidosis, endocardial fibroelastosis, and with carcinoid tumors. Remember that carcinoid tumors are going to metastasize to the lungs. They often may also be primary bronchial carcinoids. They are more common in the GIT. So it means that they are going to be found in the appendix. And remember that blood that's coming from the GIT is pretty much going to drain first to the right side of the heart. So you would expect the tricuspid valve to be affected. But in some cases, it may actually even affect the mitral valve if it's actually coming from the lungs, because the lungs are what are draining into the left side of the heart. Then remember that carcinoid tumors are going to be producing this biologically active substances, biologically active products, and these products are actually going to stimulate the growth of fibroblasts. So they are growth factors for fibroblasts. And most patients actually remain asymptomatic with mitral stenosis. They may actually not realize this unless if their body or the demands of their body increase. For example, if they have pregnancy, or that's when it begins to manifest, or if they develop an atrial fibrillation, which is a type of arrhythmia or dysrhythmia of the heart. So here's now the pathophysiology of the condition. Remember that the normal orifice is about 4 to 6 centimeter, and it's going to be reduced to less than 2 centimeters. That's when you get signs and symptoms. When it is reduced to less than 2 centimeters. Keep this in mind, because this is going to be important for us to determine the severity of the condition of mitral stenosis. So when the surface area is actually reduced to less than 1 centimeter, we refer to that as severe mitral stenosis. So what's going to happen? You have a stenotic mitral valve, okay? So it means that, remember that the mitral valve is what's blocking the entry from the left atrium to the left ventricle. So it means that there's going to be an obstruction that's going to be happening between the left atrium and the left ventricle, and therefore there's going to be an increase in atrial pressure. So there's going to be a high atrial pressure. And remember that this increase in atrial pressure is eventually going to lead to dilatation. Remember that the walls of the atria are not so thick as compared to the walls of the ventricles, so they do not necessarily undergo through that hypertrophy dilatation phase, so they easily dilate. So the atria is going to dilate, and then this predisposes it to actually undergoing atrial fibrillation, or there may be some re-entrant current that may be there that may stimulate an atrial fibrillation. Then, of course, with these elevated atrial pressures, they are going to lead to increase in pulmonary pressures, which I already explained earlier on. They are actually also going to be some pulmonary symptoms. So in order for the cardiac output actually to be maintained, then it means that the left atrial pressure also has to increase, and this may lead to left atrial hypertrophy and eventually dilatation. So there may sometimes be a decrease in the filling of the left ventricle, and this may actually cause the left ventricle to appear smaller than normal. And of course, the stress that is now put on the dilated atrium is going to be leading to possibly a fibrillation happening. And remember, when the heart is fibrillating, it's not really contracting as a whole. So it means blood is pooling in the heart. So it can predispose this to thrombi formation. So it can start to form blood clots. And these blood clots can sometimes dislodge and actually go into the cerebral system to cause a stroke. They may actually go to other organs such as the kidney, the spleen, the bone marrow, the lungs, and they can cause infarctions in those areas, which is just pretty much death of a tissue due to cutting off its blood supply. And remember that this dilatation of the atria, how exactly does it predispose the atria to cause to go into atrial fibrillation? It's because of a certain pathophysiology that's known as a re-entry mechanism, or the circus mechanism, or you can call it a phenomenon. So you have re-entry of current in the hypertrophied atrium, and then of course the atrial muscle keeps being stimulated and it's quivering and it's not really contracting as a whole. Then, so this is going to increase stasis of blood in the atrium, and of course for thrombi formation, which I already explained. Then of course you may also have an increase in the pulmonary venous as well as pulmonary arterial and the right heart pressures. Then there's also going to be an increase in the pulmonary capillary pressures. That's obviously going to be followed by edema. And then of course this when the rhythm of the heart deteriorates into atrial fibrillation with tachycardia, and it also loses its coordination of the contractions, then you may also get some compensatory mechanisms which are meant to actually compensate for these changes that are happening in the pressures on the right side. So you're going to have alveolar as well as capillary thickening, which I also alluded to much earlier on, and as well as pulmonary arterial vasoconstriction. So this is going to lead to a reactive type of pulmonary hypertension, and this reactive pulmonary hypertension could lead to right ventricular hypertrophy, right ventricular dilatation, right ventricular failure, and with subsequent tricuspid regurgitation. So that's the pathophysiology of the events that are going to be happening in a patient that has mitral stenosis. What are some of the clinical features? These should make sense. So the symptoms should be similar to those of left-sided heart failure. That's the hallmark here. Remember that the blood that's on the left side is coming from the lungs, and it's not being pumped out from the left side going to the head and the body. So it means that this blood is backflowing to the lungs to cause congestion in the lungs. So it means that there are going to be some respiratory symptoms. So the patient may have pulmonary edema, they may have exertional dyspnea, which is difficulty in breathing with exertion. So the lungs are edematous and boggy, and this actually makes respiration very, very difficult. And it actually makes it very difficult to expand the lungs. And during exertion, the right heart actually pumps more blood to the lungs, and this is actually going to be furthering more congestion in the lungs and more pulmonary edema, worsening the condition, creating a vicious cycle. You may also have orthopnea, which is difficulty in breathing when laying down flat, which is often due to pulmonary edema. You may have paroxysmal nocturnal dyspnea, which is due to pulmonary edema. I think I did explain all these symptoms when we were talking about heart failure. You may have cough with pink frothy sputum, sometimes frank hemoptysis, which is due to rupture of pulmonary vasculature. I think I alluded to that. Hemoptysis is just pretty much coughing out blood. And you may have recurrent bronchitis, which is just infections that are more likely, if you have edema in the lungs, you have more likely that you'll get infections. And of course, you may have some palpitations, and In later stages of the disease, it may progress to right-sided heart failure. So it means that you may have some systemic symptoms such as ascites, which is fluid in the abdominal cavity, the peritoneal cavity. Then you may have a tender hepatomegaly, which is increase in the size of the liver. Then you may have pitting edema of the lower limbs. Then, of course, there may be some hoarseness of the voice. Remember, as the atria begin to enlarge, then this may actually compress on the recurrent laryngeal nerve, and this may actually cause hoarseness of the voice. Then some signs. So those were symptoms. So these are now signs, what you actually elicit as a doctor. So on the face, you may have severe mitral stenosis that's going to be associated with pulmonary hypertension, may present to you with a characteristic appearance which is known as a mitrophasis, or you can call this as malaflush. So you have this bilateral cyanotic or even dusky pink discoloration over the upper cheeks, and this is often attributed to either atriovenous anastomosis and vascular stasis. And of course, you may have a characteristic type of pulse. Sometimes the pulse may be associated with a small volume, which may be regular early in the disease, and if the patient is actually in sinus rhythm. But if the patient develops atrial fibrillation, then you get an irregular pulse. So whenever you get an irregular pulse, then this patient has an arrhythmia. This patient has atrial fibrillation. Then, of course, the development of atrial fibrillation in this patient, it means that this patient is actually deteriorating clinically. You may get obvious distension of the jugular veins in right-sided heart failure. And then, of course, if you have pulmonary hypertension or tricuspid stenosis, you may see A waves on your JVP. Then they will be prominent, and provided that the atrial fibrillation has not supervened. Then on palpation, you may get a tapping impulse that you feel parasternally on the left, and this is obviously as a result of you palpating the first heart sound, and this is combined with the left ventricular backward displacement that's obviously produced when you have the right ventricle enlarging. Then you may sometimes get a sustained parasternal impulse due to right ventricular hypertrophy. You may also feel this on palpation. And then when you auscultate, this is where the diagnosis is, the clinch of the diagnosis, when you combine everything and now you listen to this person's heart. Now remember that the mitral valve is supposed to close during systole. It's supposed to open during diastole. Now the opening is where you have most of these problems. So it's supposed to open in diastole, and it's not going to open very well because it's narrowed. It's become stenotic. So it means that this is going to be affecting the first heart sound. So it means that you're going to have a loud first heart sound if the valve is still flexible, okay? If it becomes fixed or calcified, then the heart sound is going to be much softer than usual. Then, of course, if the heart valve has become calcified, you may reach a point where the pressures now in the atria are so high such that it opens up the valve forcefully, and this leads to what is known as an opening snap. Okay, so now this opening snap, you will hear this on your heart sounds. I will play you the heart sounds in the next slide. So you will hear this opening slap, or snap rather, not slap, snap. And then, of course, because this heart is filling in diastole, you're going to get a sound that you're hearing now during diastole between S1 and S2. So, or actually S2 and S1, not S1 and S2. So you're going to be getting a diastolic murmur, which is obviously a low-pitched rumbling mid-diastolic murmur. And of course, you're going to hear this best with your bell of your stethoscope that is held lightly at the apex of the heart with the patient laying on the side. Remember that this patient laying on the side, you recall that this is what we referred to as accentuation maneuvers, which make murmurs that were not so evident become evident enough. And of course, remember that the second heart sound is going to be split into two components, an aortic component and a pulmonary component. Sometimes you may get splitting of the second heart sound, and the pulmonary component may become louder, especially if you have pulmonary hypertension. And if the patient is actually in sinus rhythm, the murmur actually becomes louder at the end of diastole as a result of atrial contraction or presystolic accentuation. So here are the heart sounds. So here is a normal heart sound, in case you're forgotten. Okay, so that's a normal heart sound, S1, S2 lapped up. Then this is what mitral stenosis is going to be sounding like. Remember that you have number 1, an opening snap. Number 2, a mid-diastolic rumble, a low-pitched mid-diastolic rumble that's going to be heard best at the apex. And this is going to be heard best with the bell of your stethoscope. It's between S2 and S1. So pay close attention. Note the difference between the normal heart sound now. Note with mitral stenosis, again, I played all this sounds very well in the video on heart sounds. So if you're still not yet used to that, or you're still not yet used to this heart sounds, please head over there and check it out. Okay. So here's a summary of comparing mitral regurgitation versus mitral stenosis. But for now, I want you to ignore this on mitral regurgitation. I want you to focus here on mitral stenosis. So remember, normally you have the S1 and the S2. S2 sometimes undergoes physiological splitting, especially during inspiration. It may split the second heart sound into an aortic component and a pulmonary component. But in between the S1 and S2, there is supposed to be some silence. So remember, between S1 and S2, that's your phase of systole. Between S2 and S1, that's your phase of diastole. So what you're going to be having in a mitral stenosis is because now you have a problem with opening of the heart valve during diastole. So there's going to be an opening snap that you hear. And of course, you have this mid-diastolic rumble. And then you may sometimes get presystolic accentuation over here. Okay, remember this presystolic accentuation that we talked about in the previous slides ago. So this is your characteristic murmur that you hear. And of course, you're going to be hearing it over the apex of the heart. And of course, you may get other features here. Just to remind you, you may get some mitral phases or the malar flush. You may get atrial fibrillation. You may get a heave. You may sometimes get a tapping localized apex beat. You may get a loud S1. You may sometimes get a loud P2 component of the S2 sound. If there's pulmonary hypertension, you may also get an opening snap. And of course, this is a mid-diastolic rumble at the apex of the heart. So that's a characteristic sound that you get when you have mitral stenosis. So what are some of the investigations that we want to order? So there are diagnostic investigation and there are supportive investigations. Some diagnostic investigations include some blood investigations such as antistreptolysin O titers. These are going to be detecting the presence of rheumatic fever, because we know by far one of the common causes of this is rheumatic heart disease in the background of rheumatic fever. You also want to order a chest x-ray, an echocardiograph, which is the diagnostic tool. You should aim to order a transthoracic as well as a transesophageal echocardiograph, but a transesophageal echocardiograph is much more accurate and gives you a much better picture than a transthoracic. But in our setting, we have the transthoracic is what we routinely do. Then you also do an ECG. You may also undertake cardiac catheterization and aortic angiography. Some supportive investigations include a urinalysis, a full blood count with a differential, urea electrolytes, creatinine, and liver function test. So on the chest x-ray, what may you see? You may sometimes see generally a smaller heart with an enlarged left atrium. Sometimes the chest x-ray may be showing swelling of the left lower heart chamber. You may sometimes get pulmonary venous hypertension, which you may see on the x-ray. And then, of course, late in the disease, you may get a calcified mitral valve that you will see on a penetrated or a lateral view x-ray. Then there may be signs of pulmonary edema or pulmonary hypertension that you may see in cases of severe disease. And of course, I told you that the echocardiogram is a diagnostic tool of choice. So if on your multiple choice, they ask you what's the diagnostic tool of choice for mitral stenosis, it's an echocardiogram. Of course, this is going to be used to determine certain things. It's going to be used to determine the valve area, and it's going to be used to measure the transmitral pressure gradient. Remember that there's a pressure gradient that's going to be present between the atrium and the ventricles, which is referred to as a transmitral pressure gradient. The higher the pressure gradient, it means that the worse the stenosis. So it means that the atria has to contract much harder to overcome this obstruction. And of course, the mitral valve morphology on echocardiograph determines a patient's suitability for percutaneous valvuloplasty. And of course, it also determines the left and the right atrial and ventricular size as well as their functions. So here's how we grade the severity. So we use these parameters. We have the pressure half time, we have the mean pressure drop, and of course we have the valve area. So I want you for your level to focus on the valve area. So normally the normal valve area is between 4 to 6 centimeters square. So mild is if you get between 1.6 to 2 centimeters square. Moderate is if you get 1.0 to 1.5, and then severe if they have less than 1. Then we refer to that as severe mitral stenosis. Then of course you have other parameters such as the pressure half drop and the mean pressure drop, but I'm not going to bother you over that. For now, I just want you to know about the valve area. So on the ECG, if it's in sinus rhythm, you will see an ECG that has a bifid P wave, which is known as a P mitrale. This is owing to delayed left atrial activation. Because remember that the ECG is going to be showing you the P wave, which is showing you features of the contraction of the depolarization and contraction of the atria. So because of this delay in the left atrium activation and it depolarizing, then you're going to be having two separate P waves, kind of like an M. So this is what we refer to as a bifid P wave. You may sometimes get atrial fibrillation when you get this absent P waves, then an irregular rhythm. Then of course, as the disease progresses, you may get features of right ventricular hypertrophy, that's your right axis deviation, and you may get these tau R waves in lead V1. So here's how it looks like. So this is a normal P wave in lead 2 and lead V1. So this is P mitrale, which is going to be pointing you towards left atrial hypertrophy. So you get this bifid P wave here. Then this is a P pulmonale, which is seen in right atrial hypertrophy, which are these tau peaked P waves. Then you may sometimes get a retrograde P wave, is what we have seen here. You may sometimes perform cardiac catheterization, but this is rarely required, and it's only used if you have coexisting cardiac problems such as mitral regurgitation or coronary artery disease. If they are suspected, then right heart catheterization may be required to determine the pulmonary artery pressure in patients referred for valve intervention. So when it comes to the management of the condition, it's both medical and surgical. Medical management is going to be entailing the following things. So there are two aspects there. You have patients that are asymptomatic and you have patients that are symptomatic. So for the asymptomatic patients, you just simply want to perform annual checkups, where you take their history, you do a physical examination, you take a chest x-ray, and of course an ECG and an echo. Then of course you cover them on some antibiotics to prevent endocarditis. Then of course secondary prophylaxis for rheumatic fever. Then for the symptomatic patients, you pretty much want to give them certain drugs to control the symptoms. Remember that we're managing heart failure. So you want to give them diuretics, which may help in reducing the left atrial pressure, and it may also decrease some of the symptoms. You may give them also long-acting nitrates that can also be used if they have shortness of breath. So you want to use furosemide orally or IV, about 40 to 120 milligrams per day. Digoxin is actually indicated for patients that have atrial fibrillation, where you want to control the heart rate, since the tachycardia may further decrease the left ventricular filling, and it may reduce the cardiac output, and it may actually even increase the atrial pressure, leading to more symptoms. So you may actually give them digoxin. You may give them beta blockers or rate-limiting calcium channel blockers to improve exercise tolerance. Atenolol is commonly used orally, about 12.5 milligrams to 50 milligrams twice a day. And of course, you want to also give them anticoagulants, warfarin in patients with left atrial enlargement and right and atrial fibrillation to prevent, of course, atrial thrombi formation, and may do some to prevent systemic embolization. So you want to give warfarin orally, 2.5 to 10 milligrams per day. And of course, you should be checking your INR, your international normalization ratio. And your target is to keep your INR between 2 and 3. Then of course, you should also give your low molecular weight heparin, your Clexane, about 40 milligrams subcutaneous twice a day. And any additional lung infections such as pneumonias should be treated with antibiotics. Surgical intervention. So if you have pulmonary hypertension that develops or symptoms of pulmonary congestion that are persistent despite you actually treating them medically, then this person has to be relieved surgically. Other indications include severe symptoms or complications. Some surgical interventions include a percutaneous balloon mitral commissurotomy, which is obviously the first choice. You may also perform a transeptal balloon valvotomy. You may perform a closed valvotomy or even an open valvotomy, where you perform an open commissurotomy involving opening up of the valves at the junction of the leaflet. Of course, this is contraindicated in patients that have left atrial thrombosis. You may also perform some mitral valve reconstruction, even mitral valve replacement. Most of these procedures we do not do in our setting. Some complications of mitral stenosis include left atrial enlargement that may cause esophageal compression and lead to dysphagia. Recurrent laryngeal nerve compression lead to hoarseness of the voice. Of course, atrial fibrillation that may lead to thromboembolism. You may also have pulmonary hypertension, pulmonary hemosiderosis, which is deposition of iron in tissues. You may have right ventricular failure, tricuspid or pulmonary regurgitation, as well as infective endocarditis. Thank you for spending your time to listen to this review lecture video on mitral stenosis. If you really did love the lecture, please drop a like and a comment below to show some support. Share the link to someone who you think may benefit from this channel to Zambia and beyond. My name is Dr. Moses Kazevu.